Thank you all for your participation today in the session of the CIC National Capital Branch entitled Diplomacy of Procurement and Delivery of COVID-19 Vaccines in Low and Middle Income Countries. I would like to welcome you all and acknowledge that I'm speaking to you from the unceded territory of the Algonquin people, the traditional territory of the Wendat and Haudenosaunee Confederacy. May we honor the Indigenous stewards of this land and grow in right relationship with all Indigenous peoples. My name is Elizabeth Kingston, and I'm the president of this branch, one of 18 CIC branches across the country. I would like to thank and acknowledge the International Development Research Center, with whom we are partnering to offer a series of sessions devoted to engaging Canadians on the value of international development cooperation and to bring about an enhanced knowledge of Canada's role as it relates to international development assistance. Today, we are honored to have with us Dr. Samuel Oti and Dr. Rochelle Burgess to speak about the serious concerns regarding a comprehensive approach to ensure equitable vaccine access, particularly in low and middle income countries, especially at a time when new COVID variants are rapidly spreading in several countries. The failure of mass immunization throughout the world threatens to prolong the pandemic, thereby leading to a delay in global economic recovery. Dr. Oti is speaking to us today from Nairobi, Kenya. He is a senior program specialist in the Global Health Division of IDRC. Prior to joining, Sam was the theme leader for the Non-Communicable Disease Research Program at the African Population and Health Research Center. He is a fellow with the Royal Society for Public Health, a member of the International Society of Global Health, and founding Secretary General of the Network of Impact Evaluation Researchers in Africa. Dr. Oti will speak about the political economy of vaccine production in Africa, the responses of African governments to vaccine hoarding and nationalism in the global north, and the future of diplomacy in vaccine procurement and delivery on the continent. Dr. Rochelle Burgess is speaking to us today from London in the United Kingdom, and she will be chairing this session. Dr. Burgess is a lecturer in global health and also the deputy director of the University College London Centre for Global Non-Communicable Diseases at the Institute for Global Health, and founder and director of the UCL's Global Network on Mental Health and Child Marriage. She is a leading community health psychologist who specializes in community-based approaches to health. Her interests lie in the promotion of community approaches to health globally and views communities as a route to understanding and responding to the political economy of poor health, with a particular emphasis on the impacts of broader development issues such as power, poverty, gender, systems of governance, and community mobilization. She has written extensively to advocate for community-oriented and locally driven responses to this pandemic. Please submit your questions through the Q&A function that you will find at the bottom of the screen, and we will do our part to answer them. I'd like to take this time to thank you both very much for kindly bringing to us this most serious and timely discussion. With COVID affecting all of us so profoundly, it's most important to seek an equitable vaccine rolled out for all people, regardless of their geography or economic situation. So Dr. Burgess, as chair, the floor is yours. Thank you very much.
Thank you, Elizabeth, and thank you again for having me. As we sort of chatted in the green room, I mentioned that this is one of my first sort of formal re-engagements with the Canadian global policy arena, and so I'm really excited and honored to be asked to be here today. I think what we're talking about today and what we'll hear Dr. Oti talk about in a couple of minutes is so important. And I just wanted to reflect on a couple of things before I handed over the floor to him. Because when I was initially asked to chair the event, it sort of reminded me of the fact that about a year ago, almost to the day, but maybe a week or so away from the day, I did a public lecture on the mental health consequences of the pandemic and the inadequacies of our response when you particularly take a sort of political economy lens. And when I did that talk, I used the phrase to start the talk, which said, "This is not our first rodeo." And I really feel that there's an importance to this phrase even today, a year on, as we continue to navigate our way through the pandemic. There is often this discourse that talks about this as unprecedented times and novel space. And actuality, if you look at this through sort of a global public health or a global health lens, this is not new. We have been here before. The pathogen might be new, but the practices and the way that we're all behaving around it is the oldest story in the book. And I think as a global health scholar and somebody who's really interested in power dynamics and the importance of shifting and changing what global health looks like, the conversations that we want to have today about the political economy of vaccine rollout and the justification of countries and spaces in the global south and the rage over how things have been handled is crucial, particularly if we want to see the field change for the better, and particularly if we want to see Canada as a leader of change in this area. And I think, so I think I will stop there. I could go on, but I don't want to. I would much rather hear from Sam. So I will hand the floor over to Sam, and he will give a presentation for about 15 or so minutes. Sam, I will turn my camera back on when you've got 1 minute left, just as you're timing to help you out. And then we'll have a bit of sort of time discussing between us, and then we'll open the floor to questions. So please feel free to use the Q&A function throughout, but to say, we'll come to your questions about sort of 5 minutes or so after Samuel and I have a chat. So I haven't forgotten you. It's just the third part of the discussion. So thanks very much, and over to you, Sam.
Thank you. Thank you very much, Rochelle, and thank you, Liz. Hello, everyone, and hope you are each keeping safe and well wherever in the world you might be. I am truly honored to be participating in this forum today and would like to say thank you to specifically to Dr. Hamid Georgiani for inviting me, and to the CIC-NCB for organizing this webinar. Over the next few minutes, I'll be seeking to address the question about whether Africa's anger against COVID-19 vaccine protectionism is justified. My intervention will sound a bit bipolar, almost like an argument between Dr. Jekyll and Mr. Hyde. Bear with me, I assure you it'll all make sense in the end. I must, however, make some acknowledgements. I recognize that Africa is not a country, and I also recognize that the global north, or the West, is not a country either. And I acknowledge that each country in Africa and in the West has its own mix of context, histories, politics, and I just use both terms for simplicity. So let me start by zooming in on the COVID situation in Africa. We have around 5 million COVID cases so far, under 5 million cases, which is around 3% of the global cases, and around 120,000 deaths. Compared to the rest of the world, it appears that Africa has been so far, touch wood, spared the worst of the pandemic. But as we have seen recently in contexts such as in India, for example, things can deteriorate quite quickly. In terms of vaccinations, Africa has so far administered a dismal 2%, not 20%, 2% of all vaccine doses administered globally. And African countries are completely dependent on the COVAX initiative that is led by the World Health Organization and other multinational agencies. The COVAX initiative has so far delivered around 80 million vaccine doses to Africa's 1 billion people. By contrast, the UK alone has secured around 400 million doses for its population of around 66 million people. So in general, rich countries, mostly in the global north, which account for only 15% of the world's population, have basically secured for themselves about half of all the available vaccines. So while countries in the global north can anticipate vaccinating a plurality, if not a majority of their populations by the end of 2021, most countries in Africa will not achieve the same anytime before 2024, going by current trends. And this, my friends, is what we call vaccine inequality. Yes, there is a global scarcity of vaccine supply. Yes, countries in the global north have generally been hit much harder by the pandemic than Africa has. But does this really justify the hoarding of vaccines by richer countries? Does this really justify this so-called vaccine protectionism? And is Africa's anger against all of this at all justified? And actually, the term vaccine protectionism has been subsumed, if I may say, by a perhaps more emotive term that is increasingly being used on the African continent, and that is vaccine apartheid. And as you know, apartheid was a brutal policy of racial segregation in South Africa up until the early 90s. So why on earth are African policymakers and health experts using such a strong term in the same breath as COVID-19 vaccination levels, and are they at all justified? And my initial answer is yes and no. To support the argument in favor of yes, allow me to draw your attention to a relatively recent diplomatic spat between the government of Kenya and that of the United Kingdom. Around April of this year, the UK unilaterally placed Kenya on the red list of international travel restrictions. It completely blindsided the Kenyan government, and they were absolutely livid because they couldn't understand it. Because even though at the time Kenya was in the third wave of the pandemic, its COVID numbers were still way, way lower than that of the UK's. So Kenya's response was basically, oh, wait, now that you have secured more than enough vaccines for your people, you're discriminating against the rest of us. And let me actually read, if I may, out of a paragraph from Kenya's official response to the United Kingdom. And I quote, "Sadly, however, Kenya continues to see with deep regret that vaccine-producing countries around the world have begun practicing a form of vaccine nationalism, possessiveness, and discrimination, coupled with a vaccine hoarding attitude that can be only described as a form of vaccine apartheid." End of quote. Those are their official words. And I personally believe that this letter captures the mood across the continent. Africans are angry. They are angry with this global vaccine inequality. And they're angrier that even before the dust settles on this pandemic, Africans are already being mistreated. They are asking, what happened to the kumbaya, we're all in this together, that everyone was singing when the pandemic began? How about the leaving no one behind that we all pledged to when we agreed to the Sustainable Development Goals? And how on earth are we expected to build back better when it would take us another 3, 4, 5 years, if we're lucky, to vaccinate most of our people? So from a moral viewpoint of fairness, we can say, yes, Africa's anger is justified. But hold on. There are some who belong to a different school of thought. They say, no, our anger is misplaced and our indignation is unrighteous. They are saying, how dare Africans and African politicians in particular complain about vaccine apartheid when they themselves have been perpetrating a healthcare apartheid against their own people? They're asking, why haven't their governments invested sufficiently in the healthcare systems of their own people? Did the same African governments not all commit to allocating at least 15% of their annual budgets to healthcare way back in 2001? That's the so-called Abuja Declaration. How come only a handful, I think 2 or 3 countries have lived up to that promise ever since? How come Africa only produces 1% of all the vaccines used on the continent? It's not like Africa had no need of vaccines before the pandemic. We have millions of children, for example, that need childhood immunizations each year. And I know this is sensitive, but what about all the corruption scandals surrounding COVID-19 medical supplies from Kenya to Zambia, from Nigeria to Malawi? The list goes on. Surely, if you can afford to be corrupt during a pandemic, why should the global north care about our vaccine situation? So one might see this viewpoint as a bit too cynical, maybe self-loathing, but its proponents are simply saying that as far as vaccine protectionism, inequality, whatever you call it, is concerned, let he, she, or they without sin cast the first stone. Well, I personally think it is unhelpful at this stage to pick a side. Both ships, the SS Vaccine Apartheid, captained by the Global North, and the SS Healthcare Apartheid, captained by some of Africa's political elite, both ships have sailed. So we need to figure out now, as Africans, as Canadians, as a global community, where do we go from here? And I have two broad categories of recommendations. First, and in keeping with my ships and sailing, my horrible analogy, we need short-term solutions. We need lifeboats. And the first lifeboat, I think, is obvious. We need countries in the global north that have excess vaccine supplies to donate them to COVAX and provide additional funding to that initiative. Another lifeboat that we need is for politicians, diplomats, the civil, whoever has a voice in countries where vaccines are produced, should impress upon the biopharmaceutical companies to suspend intellectual property rights of their vaccines. And I'm so thrilled personally that President Biden's administration is officially in support of this. And I hope that other countries will follow suit. Yes, I acknowledge concerns about how intellectual property waivers might discourage innovation. Yes, I know vaccine manufacturing is complex and that IP waivers won't magically create capacity. Nevertheless, I believe the world needs this. I believe the developing world needs this, even for the mere symbolism of it. I think at the minimum that it'll be an unprecedented display of global solidarity against this awful and invisible enemy. Now, once the lifeboats have been deployed successfully, we need to plan for and invest in the long haul. You could call it building a cruise ship, constructing a Noah's Ark, continuing my horrible analogy. All I mean is that we need to prepare for the future. This is not going to be the last pandemic. Like Rochelle said, it's not our first rodeo. So we have to be prepared. And preparing for future pandemics in the context of Africa will require that first, the global community supports Africa's own efforts towards building its capacities in vaccine manufacturing and in research and development for medical technologies in general. And examples of where this long-haul support can target include support for the African Union's vaccine manufacturing initiative and its proposed African Medicines Agency. I personally believe that support for the latter is particularly crucial. At present, it is extremely complicated for a biopharmaceutical company to navigate the regulatory environment in Africa. It will need to deal with the requirements and bureaucracies of each country in Africa separately. Whereas if there was one central agency, much like in Europe, then it would be a more attractive option from a business and investment sense. So I hope that once this African Medicines Agency is ratified by the African Union, I hope that the global community will give it all the support that it needs. Another example of where long-haul support should focus on is support to the African Continental Free Trade Agreement and other efforts by the African Union to create an Africa without borders. Now, what does this have to do with vaccines? It's economies of scale. A marketplace that guarantees seamless access to 1 billion Africans is far more likely to attract the billions of dollars that R&D into vaccines and medical technologies typically requires. And lastly, the global community should continue to support research in Africa. As a person of African origin that works for a Canadian organization, I must say I've been extremely proud of the response of Canadian agencies, including the one I work for, IDRC, and others such as CIHR, in terms of how rapidly they pivoted their efforts to support research and innovation on COVID-19. For example, IDRC joined forces with the CIHR and other Canadian funding organizations to mobilize over 100 million Canadian dollars to the COVID-19 Rapid Research Fund that was launched, believe it or not, at the peak of the pandemic in May last year. And some of this funding is supporting very innovative research projects across Africa and the developing world. So in summary, circling back to my question, is Africa's anger against vaccine protectionism justified? You might call it a bit of a cop-out, but my answer is that we should never have even gotten to this point in the first place. But now that we found ourselves, then we must do all that we can as a global community to walk the talk of all being in this together and leaving no one behind. Because as any reasonable public health expert will tell you, vaccine passports or not, travel bans or not, we are not truly safe until every country, rich or poor, is safe from this horrible pandemic. Back to you, Rochelle.
It's great. You even had a few extra minutes, so it means we might have a bit more time to chat and still have a good amount of time for questions from the audience. Just to say, I don't see anything yet, but hopefully the participants will be potentially, you can also, I think, possibly raise your hand, Samuel, with tech support. If that's not possible, then please do let me know. But just as we give some chance to have some questions come through, I mean, it was such a great talk and very succinctly touching on some of the sort of, I suppose, the biggest challenges in the development and global health industry, as it were, sort of this tension between short-term and long-term action. Like, what do we do in terms of a lifeboat and what do we do to prepare for the future? The reality of sort of structures on the ground and local capacities to actually administer or respond to the challenges at hand. And I guess I just had two sort of big questions, or not too big, but two sort of questions for you. I guess the first thing that really struck me from your talk was how we often talk about sort of the challenges that countries across the African continent and across the so-called global South, but sort of those traditionally sort of the countries that still bear the legacies of colonialism as a sort of a package way of thinking about it, and sort of the challenges that they have with things like corruption, but also sort of structural infrastructure. I mean, how important is it that do you think that there is a value in still acknowledging and recognizing the way in which sort of wider global structures play a part in that lower capacity? So for example, we seem to be, in my thinking, stuck in this aid narrative, which in a way doesn't necessarily move us towards sort of that enabling and promoting the long-term change, because I think a lot of aid structure is very much responsive to crisis. And by being responsive to crisis, you only think about the emergency part of that crisis. So how, I suppose, fit for purpose is the current structure or system we have in moving us towards sort of the building of the cruise ship, as it were? And do you think that specific things need to change in order to get us there?
Wow, that is almost a Nobel Prize level question. But yeah, I think you've touched on very important things. But I think the short answer is to say that we have to live in a world where there are multiple, should I say, realities. Let me put it that way, right? Acknowledging that aid is not perfect, acknowledging the historical circumstances, colonization, neo-colonization, which is still ongoing, that are perpetrating some of the structural issues that we face in terms of capacities on the continent. Recognizing all that, but realizing that, you know, everyone has a role to play, both in terms of I don't want to say guilt, or let me just say in terms of responsibility. Let me say in terms of responsibility. And I think for the international community, we can do aid better. And I think that's a conversation that needs to be had. I recently attended this webinar on decolonizing global health. And I think it was very eye-opening to hear some of the reflections of the speakers about this persistent power imbalances between high income and low and middle income global health practitioners. So I think that aid can be done better. But I also think that, you know, African governments have their own role to play, and they need to take some responsibility for the circumstances that they find themselves in. You know, this politically extractive economic circumstances that we have, I think that's just not sustainable. If you had a spectrum in terms of political and economic inclusiveness, it's almost a no-brainer. Those countries like Botswana that are at the high end of political and economic inclusion are just doing a much better job than those who are at the bottom end. But then at the same time, there are people on the ground. At the end of the day, aid is about like making impact, it's having impact. And there are human beings on the ground that will need support, that even some of the broken or flawed structural systems, we have to cater to them. And I think that's where aid, when done better, can address some of their needs.
I think that's really fair and really important, you know, to say that you can't throw the baby out with the bathwater, essentially, right? Like we need to work with it while we fix it. There's lots of questions coming up now, so I won't ask any more. I feel like that would be abusing my role as chair. And I will sort of start to take some questions from the audience. The first one I'll take is from Margaret. She says, excellent talk. Could you expand on the desirability and efficacy of waiving copyrights for COVID vaccines?
I was expecting that question, and I was hoping, but I was still hoping that no one would ask it, because it is a very slippery slope, I would say. Again, we are in a situation that no one, well, let me not say no one anticipated. Global health security experts have been talking about a pandemic of this magnitude for many years, right? So I wouldn't say it's a surprise in that sense. But then, you know, we knew that we didn't expect it. When it finally came, we didn't expect it. And so these are unprecedented times. And I know it's a cliche. I know that phrase has been used many times. And so, you know, the idea of waiving intellectual property at this point in history, for me, this is World War III with an invisible enemy. And when you have World War, we've seen what happens when allies don't come together in a timely manner. When there's a war, when there's a world war, we've seen the devastation that can happen across the world. So that's the way I see it. That's my metaphor. I might not be great at metaphors, but or analogies or whatever. That's we are at world war. So I feel like the intellectual property waivers, even if it's just symbolic, you know, and I know, you know, some argue that it will go beyond symbolism if everyone really embraces the spirit of it, including the biopharmaceutical companies, that it'll be good for us as a society. But yes, there are concerns about how much of it do you waive without compromising the business models of these pharmaceutical companies. The R&D costs billions, so we can't deny that, right? But I mean, seeing the countries that are, I mean, like the United States getting behind it, I would never have imagined that, to be honest. I think then, at least even just looking at that at face value, there must be some merit, even if you just consider the mere symbolism of it, to doing so, and allowing other pharmaceutical companies have access to this technology. Otherwise, you've seen what's happening in India. All it takes is some crazy mutations, and honestly, we are back to square one. We are back to zero, regardless of how well your individual countries have done in terms of immunization.
Thanks, Sam. I think that metaphor is actually quite apt. I don't usually like to use the war metaphors, but it really is a battle against a very rapidly and very clever virus. It's very clever. Like this virus is doing what viruses do. And it's doing it very quickly. And the more we underestimate how truly globalized our planet is, right? You know, you can't be nationalistic and protect borders in this current world in which we live in, because borders are deeply porous. You know, we are two Canadians now living in completely different parts of the world and, you know, thinking about having families and moving across borders. And, you know, we live in a porous society, and, you know, if you want to actually protect one's nation state, to do that, you must think beyond one state, because, you know, all these borders are illusory. So another question from Francine. Thanks, Sam. We hear a lot about vaccine hesitancy in Africa and elsewhere. Do you think that vaccine protectionism and measures from the West, such as travel bans, exacerbate this hesitancy in the continent?
Yeah, so I think the Africa CDC did a study late last year, early this year, on vaccine hesitancy, and it was a problem. And again, I don't like to paint Africa with one brush. So there was a lot of heterogeneity in terms of the levels, but on average, it was around 20%. But some follow-up studies are now finding that it's rising. The levels of vaccine hesitancy across the continent is actually going up. And it has less to do with what's happening in terms of vaccine protectionism, and more to do with the disinformation and misinformation that is happening on social media in particular. At least that's the way I see it. And it's not helping that, you know, the media houses and some not too reputable sources are sort of amplifying, you know, the side effects and the mishaps, which anyone who works with vaccines will tell you is, you know, is part of the game in developing vaccines. And when you even look at the numbers in terms of the risk, you know, COVID is still a much more dangerous risk than, you know, the chances of complications from vaccines. So it's only 20%. It was only 20% in terms of people who said outright, whatever the vaccine, whether it's free or not, whatever the kind of vaccine, we're not going to take it. But that number seems to be rising because of all this misinformation that is going on.
Yeah, I think that's a really good point to highlight. I think across the world, I've actually been surprised at the ways in which misinformation can persist. And I say that as a social psychologist who spends a lot of time thinking about everyday knowledge systems. But I had thought that at some point there would have been a wider sort of acceptance of the sort of the reality of the threat that we're dealing with. But I think there is a way in which sort of this everyday knowledge, which is a lot of times shaped by misinformation or incomplete information, or sometimes outright conspiracy theories, still shapes everyday practice. And it really shows the need to not forget about that basic public health praxis that sort of has got us through all of these other points and outbreaks in the past. Another question from the Q&A chat from Akako. I'm sorry if I've pronounced that incorrectly. Please forgive me. What can we do to fast track national surveillance and response plans in an effort to avoid scenarios of poor vaccine distribution and cases of expiration, like in the case of Malawi? Any thoughts on that, Sam?
Yeah, thanks, Akacho. And yeah, so the challenge, I think, is with the word fast tracking. I'm not sure that we can fast track national surveillance if we're going to do it properly. I know that we can invest in it. I know we can build up capacities, especially if we invest in community-based surveillance mechanisms that are clearly linked to national and regional and international systems. So I'm not sure about fast tracking, but I think that the time is now. The time was actually yesterday. The time was 10 years ago to have, you know, invested in this, you know, surveillance systems for early detection and for pandemic preparedness. My bigger concern is that, like a lot of things in international development, I'm sorry to say, there'll be a big hype around this pandemic for a few years. There'll be lots of funding pumped into pandemic preparedness and response. And then once things go back to normal, we'll just, go back to the default mode, right? And so there's a whole mindset shift that needs to happen. And I honestly don't have an answer as to how that's going to happen, because I've often said, if we're poor at even investing in the health problems that we have now, if we're not that great, how much less are things that we don't even know whether they'll happen or not, or when, right? So it requires almost a leapfrog in thinking to get to that point where, right from the community level, these investments are made in pandemic preparedness and response. I know what IDRC, for example, is trying to do through our research is to identify innovative mechanisms that can do this kind of community surveillance, pandemic preparedness in potentially a cost-effective manner. So perhaps we can, invest in the research to sort of identify these models and hopefully scale them up across the developing world.
Thanks, Sam. And I would push you to say across the world. I think there's a real sort of dearth in our appreciation of the way that innovation from the global South, what it has to teach us in other parts of the world. And there's lots of, I think that the ways in which the opportunities for that are rife. And I mean, I could say a lot more about the problems of the emergency discourse in international development and our obsession with sort of whatever the hot topic is at the moment. But, global health has been beset by that. I think we are where we are today because of that discourse, that we deal with the thing that is hot right now, and we don't think about anything in the long term. And I would love for this to be different. It could be. I would love for it to be different. Another question from the Q&A. I think we have time for a couple more, if you're okay. Where am I? I've lost it. Okay, this is from Madia Ahmed, and she asks, may I ask why it's a given that waiving vaccine IP is unprecedented? We have lots of examples, polio, insulin, where there was no IP. And I want to add sort of the ways in which we dealt with HIV and the waiving of IP for ARV drugs to make. So public funding of, don't you think that public funding of global public goods makes sense? Would you agree?
Short answer is yes, but this is a political issue. That there's a lot of there's a lot of lobbying going on. There's a lot of interest. So as much as I completely support the idea of considering it a public good, it's not going to happen without a fight, and that is exactly. My question was, why did we even have to ask? Why did we even have to get to a point where we have to ask the pharmaceutical companies? Aren't they living in the same world that we are? Can't they see, the chaos that this pandemic is causing? But the world has never really operated in that way, right? Even when we talk about HIV treatment, that did not happen easily. That was a massive fight. So I think I'll be naive to say that it's going to be something that will happen easily. That's why personally I was totally surprised when President Biden actually came out to officially take a position on this, and not many heads of state from the G7 nations from the developed world have done that. So I think the jury is still out on whether it will even happen at all, whether it will lead to anything, and then whether it will prove the naysayers wrong as to whether it will indeed make a difference in terms of vaccine production and rollout.
I think that's it, isn't it? Like I think there's this way in which the world seems to wait for the US. And I thought we would have to wait a lot longer, if I'm very honest. So, I mean, I guess a follow-up question to that, because I'm really sort of interested in this idea of I suppose, political will. And so how can we see ourselves as sort of like international and global health professionals contributing to driving the necessary political will to get our government, to get more governments on board? Because ultimately national governments respond equally to national interests, and they think it's politically undesirable to be thinking about aid. I think in the UK, that's very much the discourse at the moment. They really are very inward looking. And so, what can we do, to mobilize and drive that political will that was so important in the context of HIV? I mean, we seem to have got the big one that's hardest to change sides, the US. What do we continue to do to push for that?
Yeah, great question. And what I've seen, at least in the Kenyan context, I've seen a lot of civil society mobilization to put pressure on local and national governments to support this so-called TRIPS waiver. So I think that grassroots mobilization and pressure needs to be ramped up. And like you said, about the U.S. leadership, I think it's absolutely crucial. And again, I'm curious to see how this plays out. I'm hoping, obviously, that it plays out for the better, and we have this IP waivers, and it leads to vaccine rollout, scale up and roll up. But I think it'll really take strong leadership from the United States. That's if I would just break it down to those very fundamental point. I think without the United States, they have veto power, I believe, on WTO, the World Trade Organization, and without them, even with them, getting to a TRIPS waiver requires, I think it requires absolute consensus. You can't have any dissent, and I may be wrong, this is not my field, but I think you can't have any dissent. It has to be unanimous. So great that we have the United States on board, but we're not seeing the other countries taking a strong position, because, like you said, this is is a very politically sensitive. But again, I think grassroots mobilization, civil society organizations need to be more vocal about this, and I think that was part of how we got to where we are with the generics for HIV.
I think we have time for one more. Just sort of, I'm not very good with time changes, but I think that we sort of said we were doing about 45 minutes or something. So I think we have time for one more question, if that's okay, Sam, and then we'll hand it over to Liz to close. So I have a question, and it's a bit long, so forgive me, but it's not mine. It's from S.N. Nayak. So thanks a lot for the talk. I was also expecting to hear something about procurement side of management, research on public procurement reform in Africa. What is very apparent to me is that while legislation has changed with the support of international partners, none has been committed to improving public procurement infrastructures and defending the public and the public procurement in Africa. Attention has rather been put on reforming public procurement as a way to open up the market to foreign bidding companies. Without a robust public procurement infrastructure, management of such crises like COVID will always remain a challenge. What do you think?
Yeah, it goes back to my point about, our governments in Africa taking responsibility. And I think public procurement has been, and I'm sorry to see, a massive cash cow in many contexts, unfortunately, across the continent. The Global Fund has struggled with that. Some countries are suspended, et cetera, et cetera. I totally agree that it needs reform. Now, who is going to lead that process? And as I think the West has learned, it's difficult for you as an outsider to sustainably influence political and economic structures inside a country is extremely difficult. And even within the countries, if you know anything about this so-called iron law of oligarchy, you know that when countries are gripped tightly in this extractive political and economic systems, it's really difficult to for those systems to let go. And we saw with revolutions, the Arab Spring, it doesn't guarantee, even then when there's a public uprising, that things to change. And I don't mean to sound very pessimistic, but my point is that the reform has to come from within. It has. I think that reform has to be internal. The people. It has to be internal. How we get to that point, again, going back to my Nobel Prize joke, if I knew the answer, you'll be addressing me as a Nobel Prize winner. It's a difficult one.
Thanks, Sam. I got a message from Elizabeth that we had time for one or two more. So I've got two really good ones, and then we will close. So the first one, as noted by Dr. Oti, access to COVID vaccine is unequal, and a handful of companies have monopolized manufacturing supply, limiting the scale of production. In this context, the question is, what kind of a WHO should we have to coordinate a global response to this, and future pandemics? So questions about, this is a big question that's been asked a lot lately. Is the WHO sort of fit for purpose in the way in which it currently works to sort of support and respond to crises? And then the second question is, yeah, I know.
That is
very big.
These are all political landmines. Yeah, I don't want to pick a side. So I'll sidestep that question and look more inwardly. And rather than talk about WHO, I'll talk about the African Union and what it is trying to do to prepare Africa for the next pandemic. And I think that is where the key lies, from an economic perspective, from a political perspective, and obviously from a global health perspective. So I talked about this Africa Medicines Agency, this vaccine manufacturing initiative. I think that those kinds of systems and those kind of initiatives by the African Union should be supported by the global community. And then there is the parallel political and economic processes that are going on. For example, again, like I said, the Africa Free Continental Trade Agreement, which kicked in, I think it was this year or last year. And I think, having a truly united Africa only works to our advantage, right? Because it creates this singular marketplace where we can all, take advantage of, first of all, trade across countries, and then, of course, attracting in foreign direct investment into this seamless marketplace. Because again, at the end of the day, let's face it, the biopharmaceutical companies, the biotech companies, they're not in this business out of, it's not charity for them. It is a business like any other. And so the numbers need to make sense. The investment case needs to make sense. And that is not to say that governments don't have a role. That's not to say that public funding shouldn't go into some of these initiatives. And again, that's where I think the African Union, with support from the global community, with support from the WHO as well, can play a big role. But there has to be, I think, and happy to be pushed back on this, I think it has to be the right economic incentive created by Africa through the African Union to attract the kind of FDI that needs to go into R&D for medical technologies. I just don't see any way around it. Yes, there are modular technologies coming into play in terms of how vaccines are manufactured, and that could sort of drive down costs over time. But the key remains, being able to create an environment that attracts this kind of massive investments that will need to go into R&D for medical technologies.
I think that was a pretty fair and excellent sidestep, because I guess one of the things that I've noticed and noted across this pandemic is there is a real sort of, I don't know if the word is underappreciation or over assumption. I don't even know if over assumption is a word, about what the reach of the WHO is. And I think in a lot of spaces, we often forget that national governments have to then put in their other side of the agreements that the WHO writes. And so there are these international health agreements and policies and platforms that theoretically countries sign into. That would mean we wouldn't actually even need a waiver or an agreement if they'd signed into these emergency agreements, but they don't actually do what they said they're going to do. So there's something about political will that must happen in these other countries for the WHO to actually be able to do its job. So then it just ends up looking like it's ineffective. And people saying, oh, we need a new WHO. No, we don't need a new WHO. We need people to fund the WHO properly. We need people to agree that the policies that get made up by the WHO every time these crises happen are implementable and should be implementable and are more than discourse and window dressing. Okay, one more. I promise this is the last one. You've been very, very giving of your time, and we really appreciate it. It's such a great and important discussion. And so Marcia asks, can you tell us a bit more about the recent debate at the WTO about the suspension of vaccine intellectual property? Do you know any bits about that, or any other events coming up that people might want to sort of join in on or listen to about these topics?
No, unfortunately, I don't know exactly where they are at, but I know that there is a movement. And I hear there was a meeting that was going to happen. I don't recall when. But again, it's not going to be, I don't think it's going to be a straightforward process. I'm glad that President Biden has taken leadership, but I think there's still quite a number of hurdles. And as one of the, I think, participants has rightly pointed out, it's not a silver bullet, right? It's not a magic bullet. Granting IP waivers is not going to overnight, transition into ramping up of vaccine production capacities. But again, I think there's still room to improve improve on the current situation. Just like AstraZeneca went into a licensing agreement with the company in India, I believe, and I think, if I'm not mistaken, Johnson & Johnson did the same in South Africa. I think more of that should be done. So without even being asked, I feel that more of that should be done. But it will take time. And that's why I talked about the long haul. We need to think about the future. And we need to begin to invest in this long-term thinking about preparing for the next pandemic.
Great. Thanks so much, Samuel. That's been really great. And thank you to everyone for your fantastic questions. It was a really great conversation. Elizabeth, over to you.
Dr. Burgess, thank you very much. And indeed, it was a really important and timely discussion. And the questions and the comments were just really tremendous. And I thank you all very much for your input, not only Dr. Oti and Dr. Burgess, but also all the participants who brought forth very important and timely questions. In this era of globalization, we as citizens of the world, we're not truly safe, as Dr. Oti had said, until all countries have been given the opportunity for wide vaccine distribution amongst its citizens. And, we see in India now, with all the new mutations, that we tend to go back to square one as we see these mutations arriving in Canada now, for example. So thank you both for not only this discussion, but I'd also like to thank you as well for all the outstanding work that you do in this area and continue to do. And it is just from a Canadian perspective, it really does Canada proud to see the work that you perform internationally. So thank you so much for that. I'd also like to thank Hamid Jorjani for organizing the session, and also to Sam Amwa, our technical assistants. as always, his expertise. We so much appreciate it. And I would say, given the different time zones that we're in, I would wish those within the Canadian perspective good afternoon, and I would wish those in Kenya and in the United Kingdom good evening. And thank you so much again. And perhaps we can reconvene as we move forward with this. This discussion certainly is not over. It changes from day to day, and so perhaps if we could convene at another time to pursue the discussion. Thank you so much. Goodbye.
Thank you. Bye.
Everybody.